So hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. My name is Autumn Sipus. I am the project manager with the Canadian Coalition for Green Healthcare, and specifically for the project Preparing Canada's Healthcare Buildings for Net Zero, made possible with an investment from the Government of Canada's Low Carbon Economy Implementation Readiness Fund. And on behalf of the coalition and our project team, I would like to welcome you all to today's webinar, Rethinking Nitrous Oxide in Healthcare, an Environmental and Economic Initiative. Throughout the webinar, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of our webinar today. We will also be recording this webinar, which will be sent to all registrants and will be available on our website and YouTube channel at a later time. I will now hand things off to Anita Rao to introduce today's topic and speakers. Take it away, Anita.
Thanks very much, Autumn. I'm Anita. I'm an anesthesiologist in Mississauga, Ontario, and I'm also the lead for Ontario's Anesthesiologists Environmental Sustainability Working Group. And I'm very pleased to introduce our speakers. We have Mike Apostol, who is the Energy Management Specialist and Green Team Leader at London Health Science Centre, and that's in London, Ontario. We have Asim Iqbal, who is an anesthesiologist at Vancouver General Hospital, and he's the joint lead for environmental sustainability for the anesthesia department there. We have Kathy DeKoven, who is a pediatric anesthesiologist at St. Justine, and she's which is a pediatric hospital, and she's a member of the Eco Committee at St. Justine and a member of the Carbon Neutrality Committee at the Department of Anesthesiology at the Université de Montréal. And we have Stefan Williams, who's also a practicing anesthesiologist at the University of Montreal and at CHOM, and he is the co-medical director for carbon neutrality and sustainability at for the Quebec Association of Anesthesiologists, as well as for the Department of Anesthesiology at University de Montréal, as well as for CHOM. I'm going to have Dr. Williams start. He's going to be laying the case to decarbonize health systems, as well as to discuss why nitrous is obsolete. We'll be reviewing the current clinical indications for nitrous, and really to discuss the environmental and economic inefficiency of centralized pipe nitrous distribution systems. We'll discuss how to engage stakeholders in ensuring that nitrous is not built into new hospitals, as well as our speakers will all discuss how they have been able to mitigate nitrous by decommissioning centralized nitrous in their own systems. So thanks very much, and we'll start with Dr. Williams.
Thank you very much, Anita, and thanks to all of you for taking the time to listen to us tonight. Next slide. In the next 45 minutes, we've already talked about what we're going to be doing. Next slide. And I just want to take a few seconds to talk about sustainability in a more general sense. Often sustainability is presented to us as a series of squares or a color wheel, and we can kind of pick and choose in this, and we're being sustainable. Next slide. But the best presentation of sustainability that anybody's ever given to me, and so I'm trying to transmit it to you, is that sustainability is a system that's built on the foundation of a healthy biosphere. And if we're trying to do number 3, good health and well-being, without having taken care of the climate, which is kind of the cornerstone of a healthy biosphere, nothing that we do will eventually really be sustainable at all. Next slide. So we don't want the 21st century to be one of disease, of war, and worsening climate crisis. Next slide. And so I think we need to take the WHO's perspective on this problem and be really clear that it's warming a lot. It's us, it's humans that are responsible for this with our greenhouse gas emissions. We're absolutely sure it's really bad for our health, and we can fix it, but only by no longer emitting greenhouse gases. Next slide. By climate crisis, what do we mean? We mean the extreme and destructive heating of the Earth's climate by humans via the emission of greenhouse gases in the atmosphere. Next slide. And it's easy to remember that the Earth has a very simple thermal equilibrium. Almost all of our inputs are from the sun. And all of our outputs are by radiation into space. Next slide. Between these two phenomena, we have greenhouse gases that are gaseous components of the Earth's atmosphere. They absorb and redirect heat in a loop towards the surface. Next slide. And an increase in atmospheric greenhouse gases absolutely leads to an increase in the Earth's temperature. Next slide. This is exactly what's happening now. All of the main greenhouse gases, carbon dioxide, methane, nitrous oxide, have increased in the last 100 years to levels not seen before, since before humans even existed on Earth. Next slide. And the reason for this is that humans are emitting the equivalent of 50 billion tons of CO2 into the atmosphere every year, mostly in the form of carbon dioxide, but also methane, nitrous oxide, and fluorinated gases. Next slide. The most important greenhouse gas is, of course, CO2 that comes from the burning of fossil fuels. And you can see how big 1 ton of CO2 is. While cumulative CO2 emissions by humans are at 1,800 billion tons, a number that I find very hard to imagine. Next slide. Thankfully, there's this great website called biocubes.net. It's been designed to help us visualize these large numbers. And it was built to show us that the technomass, the sum of all that humans have built on Earth at 1,300 gigatons, now exceeds the biomass, the sum of everything living on Earth, at 1,100 gigatons. And when we compare this to the man-made CO2 mass, we see that we've built almost 1.5 times more CO2 mass than technomass. And our CO2 mass is at twice the biomass of every plant on the planet. So we're not going to tree plant our way out of this climate crisis. Next slide. The only way out of the climate crisis is by reducing greenhouse gases emissions to net zero. This is absolutely necessary to stabilize the climate, and it's not possible without addressing all greenhouse gas emissions, including nitrous oxide. Next slide. So, oh, there's a slide missing. Anyways, one important thing to remember is that not all greenhouse gases are equal in terms of their capability to warm the Earth. Nitrous oxide is about 300 times more effective gram per gram than CO2. And that's why this 3-kilo E-cylinder of nitrous will warm the planet as much as this huge ton of CO2 that we saw a few slides ago. Next slide. Is it possible to reach net zero? Absolutely it is. The IPCC, the Intergovernmental Panel on Climate Change, keeps reminding us every time they put out a report, all the solutions are there. What are we waiting for? Next slide. Solving the climate crisis is absolutely achievable with existing technologies, results in huge dollar savings versus the status quo, and huge positive impacts on our security, the quality of life, and of course, our health. Next slide. Is healthcare part of the problem? Right now it is. Healthcare is about 5% of Canada's greenhouse gas emissions. It's about 5% of the world's greenhouse gas emissions. Next slide. Today's healthcare is creating tomorrow's patients. And the only way out of this paradox is by creating net zero healthcare. Next slide. The world leader for this remains the NHS, the United Kingdom's healthcare service. They've had a real plan since 2020 to deliver net zero healthcare to the country. They have ambitious targets that are guided by climate science and that they're meeting. They're spending a lot every year because the savings are exceeding the costs very quickly. And they have about 200 people working on this full time. Next slide. What does decarboning a healthcare system looks like? It looks like this. And the circle is a little bit offset. But what I wanted to show you is that nitrous oxide emissions are important enough that even when you're looking at the plan to decarbonize a whole healthcare system, it's worth dedicating a little section to nitrous oxide. Next slide. Closer to home, McMaster and the RASDQ have shown that shutting down central nitrous is one of the lowest cost, highest impact interventions that they've studied in terms of healthcare decarbonization. Why? Because nitrous oxide has few clinical indications and because central nitrous systems are expensive and leaky. Next slide. And this is where I hand off.
Thank you, everybody. I'm just going to go through a brief history of nitrous oxide and anesthesia. So it was first isolated by Joseph Priestley, an English chemist in 1772, and later recognized for its analgesic properties by another English chemist, Humphrey Davy, in 1799, who coined its more popular name laughing gas. It became firmly established as an anesthetic agent by an American dentist, Horace Wells, who used it for a tooth extraction on himself after he saw the American showman gardener Quincy Colton demonstrate its effects at an exhibition. Nitrous oxide delivery through medical gas pipeline systems has been in use in hospitals since 1930, going hand in hand with other inventions and discoveries such as anesthetic vaporizers. To state the obvious, medical gas pipelines are a key element of every hospital. So nitrous oxide has been in use in anesthesia in hospitals for a long time, and it generally has a pretty safe record, but not completely safe. In 1973, there were at least 9 deaths because of an error in cross-connection of nitrous and oxygen piping in the newly constructed wing of the former Sudbury General Hospital. Almost identical deaths occurred in the UK during the 1970s too, and a similar incident happened in Italy as recently as 2023. And these patients died because they breathed in pure nitrous oxide instead of oxygen, high concentrations of which displace oxygen in the alveoli, causing hypoxemia and eventually death. To be used safely, its inspired concentration must not exceed 70%. Since 1973, gas pipeline systems have been subject to rigorous oversight during installation and require regular monitoring and maintenance according to the Canadian Standards Association. And all of this requires tremendous human and financial resources. Next slide, please. Because of a wide range of concerns, the use of nitrous as an anesthetic adjunct is declining in Western countries. It was used almost ubiquitously when I started my anesthesia residency 20 years ago, to being used in only 21% of surgeries in 2011, and I suspect its use today is even lower. Currently, nitrous is mainly used for dental procedures and labouring obstetric patients, as well as in the emergency department. Its traditionally biggest use at the operating rooms has reduced its usage massively. The issue is that nitrous is piped into all of these areas in almost every modern hospital. And as Stefan mentioned, these pipes leak, and the leakages account for nearly 85 to 99% of clinical nitrous oxide use. Next slide, please. So why has this use declined in anesthesia? It's multifactorial, but big issues include its role in causing post-operative nausea and vomiting. Most guidelines now recommend omitting it from day surgery completely. Newer drugs such as remifentanil have superseded nitrous's use as an intraoperative analgesic or volatile anesthesia, and the increasing use of total intravenous anesthesia is reducing anesthetic gas usage in general. Nitrous also has a tendency to accumulate in gas-filled spaces in the body. Because of the higher blood solubility of nitrous oxide and nitrogen, nitrous oxide transfers faster into closed gas cavities than the nitrogen is removed, leading to expansion of these cavities. Because of these concerns, nitrous oxide is relatively contraindicated in bowel, laparoscopic, middle ear, and eye surgery, with caution advised in neurosurgery. Attention must also be paid to the potential effects of increased volume in other airfilled spaces, such as tracheal tube cuffs, laryngeal mask airways, and pulmonary artery catheter cuffs if they're used. Nitrous oxide irreversibly oxidizes the cobalt ion in the center of vitamin B12, and vitamin B12 is a required cofactor for an important enzyme involved in the chain of DNA production, methionine synthase. After several hours of nitrous oxide anesthesia, activity levels of this enzyme are very low. Mild megaloblastic changes, megaloblastic referring to the kind of strange morphological changes that occur in cells, are present after 12 hours and are marked after 24 hours. After several days, complete bone marrow failure is expected. B12 or folate deficiency leads to subacute combined degeneration of the spinal cord, presenting as limb weakness, numbness, or tingling with imbalance. Patients with subclinical B12 deficiency, which may be up to 15% of the population, are especially at risk, and rare cases of myelopathy have been recorded in the past from occupational exposure. Nitrous oxide may reduce fertility and increase the rate of spontaneous abortion in female workers with chronic exposure. Areas that do not use anesthetic gas scavenging systems or have inadequate ventilation, such as recovery areas, dental suites, and radiology, are at risk of exceeding exposure limits. Next slide, please. Proponents of nitrous oxide may argue that it's useful for the second gas effect. This is where nitrous oxide, when used, transfers across the alveolus rapidly because of its high solubility. And this leads to concentration of the remaining gases in the alveolus, namely the volatile anesthetic, and increase the driving pressure of the volatiles into the blood. The second gas effect, in theory, works to increase the speed of onset of anesthesia when using nitrous oxide, but does it really? With new agents like sevoflurane, this benefit is negligible at best. Studies in adults and pediatrics showed that the time to loss of consciousness with inhalation or induction is similar or only slightly increased without the addition of nitrous oxide. Next slide, please. So far be it for me to tell individual anesthesiologists as whether they should be using nitrous or not, but due to its decline in its clinical use, it's undeniable we are now training a generation of anesthesiologists who have little use or familiarity with it. This decline will therefore likely perpetuate itself. For the minority of anesthesiologists that do use it, the question I have is, do we really need a central hospital pipeline for its use? Given that pipeline leaks count for approximately anywhere from 85 to 99% of its use, I would say the answer to that question is a resounding no. Stefan already mentioned the global warming potential of it, and nitrous is a gas. It's one of 6 gases that are regulated under the Kyoto Protocol, and this is all the reason to use it more efficiently. For people that like to still use nitrous, with all this wastage and environmental harm in mind, its use can alternatively be accommodated by retrofitted cylinders to the back of the machine, a cylinder holder in the OR connected to the anesthesia cart, or in the delivery suite, a lean supply of nitrous oxide can be used, or portable dollies with regulators. And these are all viable alternatives. Next slide, please. Nitrous oxide in anesthesia has become almost obsolete, and it plays a very small role in modern day anesthetic practice. With all the aforementioned issues with its use, there's growing international consensus from all the major anesthetic societies to avoid or eliminate nitrous oxide from routine use. Thank you very much.
Thank you. And the next 5 minutes, I'm going to take a little bit of your time, to tell you what happened with nitrous at the CHUM, which is both Quebec's largest and newest hospital, with about 1 million patient visits a year. Next slide. There you go, 18,000 people work here every day, and it's just been built. Next slide. And unfortunately, our brand new hospital has ended up on Canada's map of worst greenhouse gas emitters, mostly because of our egregious use of fossil natural gas, but also because of other greenhouse gas emissions. Next slide. The CHUM has a 32-suite main OR, plus interventional radiology, radio-oncology, burns, dentistry, obstetrics, more than 50 anesthesiologists working there. We did about 19,500 cases last year, about 55,000 hours of anesthesia care. Next slide. We do long cases. Central nitrous at the CHUM was installed only in the main operating room. After a very brief discussion with anesthesia that didn't take into account the costs or the environmental footprint or the way the use of nitrous was evolving. It was not installed in obstetrics, not installed in burns, not installed in dentistry or the emergency room, because the projected use, of course, didn't justify extending central nitrous to these areas. And the way central nitrous worked at the CHUM is that huge K cylinders containing about 29 kilos of nitrous, or about the equivalent of 9,000 kilos of CO2 for each cylinder, were used to pressurize this central pipeline. Clinically, what was going on during this time? N2O was really out of fashion. It's been out of fashion at the University of Montreal for about 20 years for general anesthesia due to negative side effects and environmental harm that were just discussed. A few anesthesiologists will sometimes begin emergency C-section under general anesthesia with nitrous before switching to another technique, and they use 3 kilo E-cylinders, and they have since the CHUM was opened. outside the operating room. 50/50 nitrous oxygen in pre-mixed cylinders is used occasionally by OBGYN. But the main use for nitrous at the shim has become cryotherapy, interestingly enough, and they only use E-cylinders. Next slide. So the shim is not unique in Quebec in using very little nitrous for anesthesia. A survey done in June last year, before a lot of this nitrous literature was promoted in Canada, showed that already almost half of Quebec departments had shut down central nitrous, and more than a third had no clinical use for the agent at all, and the rest had either limited or very limited use for the agent. Next slide. This is the story of nitrous at the shim. K cylinders, we burned through 42 our first year and 27 our second year. This was because of commissioning of the system, we were told. And then I told you about our clinical use, so we ended up going through 0 K cylinders for a couple of years, because essentially there's 0 clinical use. And then by the 5th, 6th year, 36 K cylinders appeared on our purchasing again. And when we asked why, we were told it was because of leaks and maintenance. Next slide. So anesthesia discussed with our building engineers, and we asked them to decommission central nitrous because we felt that the cost and the maintenance and all this work and all these emissions were absolutely not justified by clinical use. In the absence of clinical demand, cost savings related to testing and maintenance of the central system made shutting down central nitrous a no-brainer. So tanks and fittings were removed and capped off, and portable 3-kilo nitrous E-cylinders were made available on demand. Next slide. And the demand for, these are the wrong numbers, but anyways, the demand for E-cylinders in the anesthesia in the past 2 years has been 0. So the 55 anesthesiologists at the shim in the last 2 years have used less than 1 E-cylinder. Other clinical users, as I said, are using small volume still. They were already using E-cylinders, so they didn't even notice that central nitrous was shut down. And reducing their clinical use is a work in progress. Next slide. And here's where I hand off again.
Yep. So I'll take it on from here from a facilities perspective. So, yeah, so centralized distribution systems have very high leakage rates. Everyone that's investigating this at their hospitals are finding this. The table on the top right there, each of those horizontal lines is one of the Providence hospitals. So they audited, I think there's 30 some odd hospitals. The blue portion are what they did, what they were purchasing, and the little gray portions at the end are what's actually being used clinically. There's implications to this. We don't really know where the leaks are all the time. They can be on the flexible hoses, they can be at the ports, there's throughout the manifold areas, and potentially impacting indoor air quality, which is a occupational health and safety concern. They're also a substantial source of healthcare greenhouse gas emissions when you actually account for it as a scope 1 emission. Next slide. So here in Ontario, a number of us hospitals have started doing our own audits at LHSC. One site's about 90% leakage. Our other site is 99% leakage, as we just don't use it, but are continuing to replace all of our tanks. Again, Trillium Health Partners, Sunnybrook, Vancouver General Hospital, CHUM, all these hospitals are finding same sort of thing, very high leakage rates, even with regular maintenance being done by facilities at their sites. And that's a lot of greenhouse gas emissions unnecessarily released into the atmosphere. Next slide. So benefits to facilities is reducing the cost and scope of your hospital's medical gas audits and repairs. I'm aware of what we do here. They take a long time. It'd be nice to get rid of a large chunk of that audit. You'll free up space in your centralized tank storage areas. Space is always a premium. And then just the human factor side of it, you're reducing potential injuries from having to care for your med gas supplier to bring in those tanks and potentially have an injury. The purchasing of the actual nitrous oxide itself is usually not by facilities, it's by respiratory therapy, but you're going to help reduce their costs as well. So bottom right there is just like a layout of a distribution system on one of our floors. And then bottom left shows the amount of leakage. This slide's kind of small in here, but the amount of leakage with the different types of centralized systems. So the first one on the left is with the cryogenic cylinders. Those things just off gas all the time. So not even in the distribution side, if you have cryogenically frozen nitrous oxide, you are off gassing N2O everywhere. Next is the standard kind of large K tanks, a little bit less leakage, but still leaking quite a bit. And then the best solution is kind of E-cylinders at point of use. Next slide. So there's sort of three phases in decommissioning existing systems. It's the assessment, establishing the portable supply plan and implementing it, and then the phased in deactivation of the central supply. There's four main stakeholders. Of course, you're going to be engaging with everyone in all the various departments as well, but you'll have a project coordinator that's running it, a facilities lead, an anesthesia lead, and an OR director. There's a checklist that I'm sort of referencing in this. This will be available on the Next to Nitrous website in the coming weeks, I hope. And next slide. So if we look at the first stage, the assessment is kind of what we've all been talking about. You're looking at your current purchases of tanks and you're comparing that to the clinical usage. You'll be wanting to talk with biomed most likely to get that clinical usage. They can go into the anesthesia machines and actually typically that amount of N2O is recorded inside of there. Then you can do estimates for other departments as well if the maternity ward is also, or labor and delivery is using it too, same with dentistry, etc. Once you get that, you'll get your most likely, oh, wow, yeah, okay, it's over 95% leakage estimate. And then you can analyze your system, look at all the various ports, outlets, manifolds, however many systems you have. And then you can sort of do rule of thumb estimates for how long it's going or how much it's going to cost to actually decommission it from a facilities perspective. You can also work with your med gas supplier, like Class 1, to talk to them about how much a decommissioning of the system would cost. So next slide. So once you've done the assessment and you're ready to go on the project, you want to actually set up the portable supply system. So you're going to identify all the clinical use areas and engage with them. This is pretty critical because at least at our hospital and many others, due to the CSA guidelines, we pipe it everywhere, or a lot of places that do not use it. And so engaging them is interesting because you're like, hey, you have 8 med gas ports in your area. How much you use nitrous oxide? And they say, we've never used it, never would use it, don't know why it's here. So that's a great thing. Makes the decommissioning process a lot easier. I like tagging the ports at this stage as well. This helps, and it's just information about the project, just in case anyone is like, oh no, we actually do use it once a year. You'll want to, for any places that are using it, you'll want to work on the periodic automatic replacement level and where those tanks are going to be stored, establish that, figure out where it's going to be and what the process is for doing that. Once you have that all ironed out, you're going to actually implement it and get everything ready. Next slide. And then you're just into the deactivation phase of the project. So you're going to confirm with everyone that you're going to be doing a deactivation kind of trial, if you will. So what you do is you essentially just disconnect everything from the centralized system, but you leave the system pressurized for a specific amount of time, let's say 1 to 3 months. And then everyone gets a chance to work through the new portable system. During this time, you're going to label all the outlets, say, hey, this is going to be decommissioned, use the portable system. In an emergency, you can still use it if you need to. That's why you have this phased-in approach. Once you've solicited all your feedback during this trial period, then you move on to the actual depressurization, communicate with everyone hospital-wide, all the managers, make sure everyone's aware that this is happening. Then your team is going to disable the alarms, close the valves, downstream to the main manifold, and then you will start deactivating everything. You can wait after the depressurization stage if you want for another trial period. That's up to you and your teams. But then once you go to actually deactivate, you're removing tanks, manifolds, hoses, disabling the alarms, valves, and outlets. Next slide. So some of the things to keep in mind, you do not actually need to remove all the distribution piping unless you want to. The CSA guidelines around this are somewhat ambiguous, but you are allowed to leave all the distribution piping in the walls and ceilings in case the hospital ever decides to re-implement a centralized system. Depending on your site and your facilities kind of protocols, it may be you may internally decide to remove it. It's typically a lot of work and quite a bit of cost, but you are allowed to leave it in. Med gas drawings, when you're going through those, and the vendor audit list may not be up to date and or accurate, so do take some extra time to make sure you can get the most up-to-date information, and definitely just communicate. So we're going to be releasing a number of resources on the Nixon Nitrous website about how to go through this decommissioning process. And so there's a nice toolkit that is basically a Canadian adaptation of the Cascadia Nitrous Oxide Collaborative toolkit. They were very generous and let us they absolutely said, yes, you guys can use this, make it Canadianized, just let everyone know that, we developed it. So that's what we're doing. There's a really great decommissioning checklist that helps make the process easy. And then we'll also have a little cost estimation tool that you can play with as well to just get, rough orders of magnitude. Next slide. So that's decommissioning existing systems. New hospital builds are obviously the ideal time to nix the nitrous. Engage as early as possible. These are get everyone in a room, architects, engineering consultants, hospital and clinical leadership, facilities project managers. Show them the evidence. The clinical usage is declining and likely being eliminated over the coming years if it's even used by any anesthesiologist. Show them the historical leakage rates at other sites. We'll have tons of resources that show this. The environmental impact of the leaks as well, giving it perspective on what the implication of that is. And then obviously the cost savings on a new build. Yeah, probably millions of dollars for like just the nitrous oxide lines alone and all the associated equipment that goes with it. Ongoing maintenance costs are mitigated, and obviously the ongoing purchasing cost. Already we've seen one engineering consultant from HH Angus put a kind of like a little article online basically saying like, we don't recommend centralized nitrous oxide anymore. So engineering consultant firms and architects are understanding that this is a change that's coming. So just make sure it gets visibility in any new projects that you're aware of. Next slide. Thanks.
Hi, so I'll be talking about a pediatric example of decommissioning of nitrous oxide pipelines. Next slide. I work at St. Justine. It's a big pediatric and obstetrical hospital, a quaternary center, very busy hospital, big center. Next slide. Back up, please. I seem to. Okay, maybe forward. Okay, and then we'll back up after. Okay. It's been quite a while since nitrous was decommissioned in our center. It's back in 2010. I think actually the director of the SHIM was the director of St. Justine then at the time, interestingly. So we were starting to do our renovations in the hospital, and it became clear that the nitrous network would need to be redone. And our chief at the time, Dr. Sylvain Matthews, suggested that instead of redoing the whole network, that it would be cheaper and better for the environment for us to just use portable and external nitrous in places where we needed it. So it's been discontinued in my hospital for over 10 years now. thanks to Dr. Matthews, we also slowly had a fade out in the use of desflurane, another greenhouse gas emitter. And we no longer have any desflurane cylinders to be found in the hospital. I spoke with Dr. Matthews last week, and he said that it was really an easy, smooth process doing the decommissioning, that there was very little friction from anybody in terms of going through the process, and that quite a bit of money was saved as well by going through with it. At the time, he checked with members of the department to see whether we would be willing to just forgo having nitrous at all in the OR. But at the time, about 50% of the staff surveyed still wanted to have nitrous oxide on the backs of our machines. So that's what we did. I think go forward first. I'm not sure why the orders got mixed up, but go forward. Sorry, no, go to that apple and there, that one, that's good. Then later we'll go back to the other one. So fast forward to 2023. And in our hospital, we started to have an eco committee that had doctors and pharmacists of the hospital working on the committee. And just the presence of that committee alone was really helpful for affecting all sorts of environmental changes in the hospital, because it just gave legitimacy to any sort of sustainable projects that people wanted to bring forth. I was also inspired by the publication out of Seattle Children's in 2023 of Project Spruce by Elizabeth Hansen and her team, where they published basically a blueprint for reducing emissions related to anesthetic gases in a pediatric OR. And so I took a look at that article. Also with Myriam Couture, who's a respiratory therapist that I work with, who is involved with buying all of our anesthetic equipment. And together we decided that the lowest hanging fruit of the best first project to do would just be to reduce the fresh gas flows in the OR, because at the time our maintenance gases were at 1 liter per minute. So we reduced those. Miriam reprogrammed all the machines so that they were at 0.5 liters per minute for maintenance gases. And we also used that table that you can see for reducing the flow for induction gas flows based on the weight of the child. So now actually, I guess go back 2 slides, please. That's it. Yeah, that's great. So so the next step was to try and I'm realizing I'm still missing a slide. I'm not sure what happened with the orders, but I know what I want to say, so I'll just go with it. So the next step that we decided to do was to go with nitrous oxide. This was a bit more of an ambitious target because a lot of pediatric anesthesiologists and some obstetric anesthesiologists can be pretty attached to our nitrous oxide. There's particular uses for it that some people feel very strongly about, in terms of mask acceptance, which it's been shown that nitrous oxide actually doesn't increase pediatric acceptance of masks versus placing a sevoflurane mask. Also, in adolescence, often people will use nitrous oxide to place the IVs to do an IV induction. And as it was said before, we also sometimes use it for obstetric stat C-sections, and also outside of the OR for procedural sedation. And some ENT surgeons will also rarely ask for it to extend the tympanic membrane when they're doing laryngotomies also. So I apologize that there's kind of people's faces here, because I blacked that out before, but pretend you don't see any sort of snowy faces in the surveys. But the first thing that I did is I sent out some surveys to members of my department through our WhatsApp link, to be able to get a feel of how what people's opinions were. And so in the first survey was asking if people would feel like they could anesthetize all of their patients without nitrous oxide. And over half of the respondents said that they would be able to, but 5 out of 11 said either it depends or no, I need my nitrous. And so then I talked with people a little bit to get a sense of what the reasons were for it. And so then I suggested maybe we could just keep nitrous cylinders in the emergency OR, in the ENT OR, in the obstetrics OR, and also in the cardiac OR for placing IVs in really fragile patients. And still there was one no. Somebody still wanted their nitrous. And so we can go forward a few slides. until we get to the one with the cartoon. You can skip that one. Actually, okay, yeah. So at this point, I was dealing with wanting to be able to figure out how we can reduce the nitrous without alienating certain people in the department. And I neglected to mention in the last slide, one thing that we had noticed was that in 2024, before we'd done any changes with the external cylinders in the OR, that we had that 41 cylinders of 3 kilograms, like the E cylinders, had been delivered to our operating room. And this is despite the fact that actually most of my colleagues don't use nitrous often. We all like knowing that we have it, but it's not something that's used very often. And so looking at it with Miriam, we realized that possibly a lot of our nitrous loss is actually through the morning tests of the machines, that it might be that's actually using up the most of the nitrous. So so there was more discussions with people. In this cartoon, I'm definitely not that cat. I'm more the dogs, like the people pleaser, and I'm not an influencer. So this was all very challenging for me to try and do something where there wasn't unanimity. So we can switch to the next slide. And so there had to be a lot of conversation, slowly but surely. We managed to come up with a roadmap for how to go about doing this through a bunch of conversations, emails, department meetings, talking to Stefan also at a climate fresque at his place. And through all of this, we ended up coming up with a plan. So basically what ended up happening is that one of my colleagues who's better at French than I am, wrote an email because I work in French and it's my second language. But so one of my colleagues wrote an email to the rest of the department saying that what our plan was to shut the valves of all of the E cylinders of the nitrous oxide in the ORs. And when we would do our morning tests of the machines, we would just bypass the part in the test that talks about nitrous oxide. If anybody wanted to use nitrous oxide, they would have to have the foresight to have 4 or 5 minutes to retest the machine with the nitrous valve on the cylinder open, to be extra secure, to be sure that we were giving what we thought we were giving. And so we sent an email saying that that's what our plan. We sent that out at the beginning of December. We could switch the slide again. And it was crickets, like nobody said anything after we sent the email. So a week later, we just shut all the valves on the nitrous cylinders, and nobody said anything since. This was at the beginning of December. I haven't heard anything. In about 6 months, we'll check to see how many nitrous cylinders have been used. So I'm really excited to see the results for that. And then I just wanted to go over very quickly a couple more slides. We could go forward. I just wanted to be sure that if there's anybody in the audience who's doing pediatrics, that you're aware of this application, PediPop. It's a free application that I find really helps with mask acceptance with sevoflurane. It's really cool because what you do is that the child will choose a color balloon, and then you put the mask on and you instruct them to start blowing up the balloon on the phone. And so it's almost like a virtual reality thing where the kid is interacting with you. And it really works super well for distracting them from the smell of sevoflurane. So this is something that I'm still surprised at how well it can work sometimes, even with really difficult patients. It's not perfect, but it's at least as good as using nitrous oxide for mask acceptance. And then next slide. So also just a lot of psychosocial stuff of having parental presence, preparing the child pre-op, having child life specialists. All of these things can make it so that the child will go into the OR more willing to accept the mask, and possibly that we could even place an IV in the holding area before bringing them in. Next slide. And other options are for pre-med medication or medication for procedural sedation, midaz, ketamine, fentanyl, dexmedetomidine, PO intranasal, and very rarely IM. And last slide. We like to use also Maxilene, which is a topicalizing and anesthetic, which works faster than EMLA It takes only about 20 minutes to freeze the skin, so that can be useful also for putting IVs on. And I was discussing also with my emergency colleagues, and I would be remiss if I were not to mention that they still feel that there's a place for nitrous with their portable cylinders that they have in the ER, and I understand them for some of the more painful short procedures that they're doing. I think that maybe something that we might want to look at in the future is trying to implement one of the technologies for capturing and destroying nitrous oxide in those situations. The technology already exists. It's called cracking nitrous oxide. So this is something that I'd be curious to look into. And that's it. Thanks.
Okay, thanks very much to all the speakers. Just have a couple of slides more for references, just to show that IHI, Association of Anesthetists, and NHS, which were the leaders in really decommissioning and nitrous mitigation. And next slide, please. And in Canada, the CAS has just come out with, that's Canadian Anesthesiology Society, has just come out with their environmental position statement, as well as in their guidelines to the practice of anesthesia 2023 updated report has also said eliminate or restrict nitrous as much as possible. Quebec and Ontario have put out position statements asking to restrict the use of nitrous. So this is all supported by best practice, and also with previous slides, we've shown that the ASA and the WFSA also support. So for anyone who's not an anesthesiologist in the audience and wants to make sure that professional practice supports nitrous mitigation, it certainly does, and there's lots of evidence for that. And if you're having any pushback, we can certainly help. And I think that's it. Autumn, do you want to see if there's any more? Okay, perfect. And so we're happy to take questions and happy to direct those questions to whichever speaker you'd like. So you can put your questions in the Q&A. Or in the chat, either would be fine. I'm just going to ask Kathy a question because I find this really interesting that after a few months, you've actually had nobody who has commented about the nitrous, because presumably they'd have to open up the cylinder and retest in order to use. And I think that in itself is kind of one step on the change management ladder of restricting nitrous use. And has anyone, so no one has said anything to you?
No, for the nitrous oxide, nobody has said anything. One thing that I forgot to mention is that I think that a lot of my colleagues are pretty sensitive to the negative environmental impact of nitrous oxide. And I think that anybody working in pediatrics probably should be. So, I mean, anybody should be, but anybody working in pediatrics in particular really should be, since children are particularly vulnerable to health problems related to climate change. So really in the long term, we would be doing our patients a disservice if we were to grip onto our nitrous oxide. So I think that that might help a bit in terms of the perspective of my colleagues. There were a few respiratory therapists who weren't thrilled when we decreased the gas flow. The first step that we did with the sevoflurane, there were a few complaints at first that some people found that the inductions were not quite as fast as they were used to with the reduced gas flow. And I was hand wringing a little bit about it. And I went to go talk to Miriam, who's one of the responsible people with the respiratory therapist. And she was like, just give it a few weeks and you'll see, like, everybody will be fine. And after a few weeks, nobody said anything. So it
Yeah,
was, yeah.
that's great. Okay, excellent. So we've got some. So from Caitlin here we have, is there any recommended protocol when decommissioning to ensure the lines don't get repurposed accidentally, like a tag out system or laboring protocol? And I think some of those answers are actually in the chat, but I'm going to hand this over to Mike.
Yeah, all the outlets get essentially capped and blanked out, so it doesn't even show nitrous oxide anymore after you're done decommissioning them. Same with the valves, where those are the panels in the hallways. Those valves again unlabeled, and then the pressure gauge removed most likely, so that it's not scaring anyone. They're like, oh no, our pressure is gone. So yeah, no, it is not accessible with a proper decommissioning process.
Okay, great. Jeff Wasserman, one alternative to nitrous in the emerge is methoxyfluorine pens. Is anyone or anyone's ED using this, and does anyone have an idea of what the environmental impact is? And that's the new, so methoxyfluorine, very old anesthetic, now sort of being marketed for short, painful procedures. Of course, has same contraindications as other volatiles, so not for MH. And our place doesn't have it, but I know some of our gynecologists have talked about it for IUD placement. Is anyone, anyone on this panel, is anyone using methoxyfluorine for short, painful procedures in the emerge?
There is some discussion about this in our hospital right now, and greenhouse gas emissions associated with methoxyfluorine are much lower, but the pharmacokinetic properties are not really the same. This is you inhale a few milliliters and it lasts an hour or two. So I'm not sure it's going to answer the clinical need where nitrous is still used by OB/GYN, but we're going to try it out.
Okay, great. Colin Chan had just asked about scavenging for portable systems, and yes, scavenging does have to be used in the Pronox, the Pronox portable stands. They have all of it all together. So yes, if it is being used on a portable stand for a short procedure, even for IV insertion or for obstetrical analgesia, it does need to be scavenged. I'm just going to switch over to the chat. So Kent, I'm curious how many hospitals have completely ripped out their centralized lines, plumbing, and at what cost? Kent, we decommissioned a year ago completely at our orthopedic center. Certainly the piping is still there. On January 27th, we're going to be starting with our other two hospitals, and we are leaving the distribution piping in. Mike, you probably...
You went on mute there, Anita. Yeah, I'm unaware of any hospitals so far that have completely ripped out the pipeline. The CSA guidelines are somewhat ambiguous though, so I think that is a barrier when people are initially looking at this, but we are trying to get the word out that no, you're blanking out the ports, doing the alarms, valves, manifolds, and you can leave the actual pipe in the walls and ceilings.
Is there anybody on the webinar who's involved in a new hospital build that would perhaps like to discuss whether they know or don't know if they're getting a centralized distribution system for nitrous oxide? We had some questions from St. Paul's Hospital previously. Anybody hear from there? Working on the build. Peter Manikevs is, yes, St. Joe's is getting a new tower. North York is planning, so I'm sure you two have that under control. There will be no centralized nitrous. Edward, can Autumn can we give voice to any of the attendees?
Yes, we can.
Edward, do you want to just speak about the hospitals that you were involved with?
And this is
Edward Hood. There. Okay, perfect.
Okay, can you hear me?
Yes.
Yeah. Okay, so We're involved in quite a few hospitals, either currently under construction or ones that are in the early stages of design. We have, for example, on Trillium, we did request the deletion of the nitrous. I sit on the mid-gas technical subcommittee, and Stefan had given this presentation earlier in 2024. So I'd written a guideline and a bulletin internally in our office and sent that out also to a number of our clients, advising to potentially look at alternate ways to deliver nitrous oxide instead of through the pipeline. So for Trillium, I understand for the Mississauga job, that was removed. In South Niagara Hospital too, there was a requirement for a central nitrous that was removed. Cowichan District Hospital, which is currently under construction, I'm working on, that was removed. So we've seen an uptick in facilities being very receptive to looking at alternate ways to deliver nitrous, and I think it's the right approach.
Edward, do you know what the cost savings were on some of those deletions? Did that get back to you?
It didn't get back to me directly, so I can't speak to those. But I mean, there was there was a fairly substantial saving, but I wouldn't know off the top of my head because each of those were a different size, and it depends on some of the contractors in terms of what their markups are. They weren't all being done by the one main mid-gas supplier that we're aware of, so there may have been some difference in terms of the how much credit was given back to the deletion of those systems.
Gotcha.
One thing I did want to mention too, though, just in terms of scavenging, is that the CSA standard, if you're using nitrous as an analgesic, there is the potential to not require an AGSS system to scavenge that. You could use your ventilation system. It's only where a patient's using nitrous oxide for anesthesia that you must have the anesthetic gas scavenging system as well, in addition to the ventilation requirements laid out in CSA Z 317.2.
Thanks, Edward, for clarifying that. And just to give our experience at Trillium, from the time I brought it up to going through our development committee to getting all the approvals from all the various departments, and then to bringing it to the engineers and architects and to your team, Edward, was about 6 weeks. It was probably the easiest implementation I had done. It took me 2 years to change a plastic K basin to a stainless steel one. And this was 6 weeks, and everyone was on board because it saved money and it was supported by evidence. And it saves money ongoing. It's not even just for the build. For us, we're $90,000 a year, really just in maintenance and testing because we don't use it. And so there's a big savings. So thanks, Edward, for all your work in the various hospitals and promoting this.
Oh, you're welcome, and thanks for bringing it to our attention. Annex P in the CSA standard, we'd had that for a while now, about informative annex about, hey, check if you really need this or not. But the presentation that was put to the TSC last year really struck a chord with me, and I think with all of the members, to get out in front of commissioning teams as well, compliance teams that are often responsible for writing output specifications, and sort of saying, look, this isn't about trying to cheap out on a build, it's about doing the right thing.
Right, correct. Let's see if there's nothing else in the Q&A. I'm just going to look quickly through the chat. Okay, so Kent said that he spoke to facilities managers at Chess, and they both said nitrous piping had been demanded and is being built into their 2 new buildings. Okay, so we don't know what those are. Unfortunately, if it is being built into new buildings and there's no clinical use, which is really where the direction we're going to is decreasing and decreasing clinical use, that will all be wasted money, effort, and most importantly, carbon emissions. So it would be great if anyone is involved in any of those bills to reach out to us directly. And at the Nitrous with this group and with Autumn, and to reach out, and she can reach out to one of us, because we really do not want any new hospital build, and there are several across the country, to be installed with centralized nitrous. Ted has a question. For anyone who is decommissioned, what challenges have been experiencing in silencing alarms for combined gas panels? Mike, I'm going to hand that to you.
Yeah, I personally have not gotten to that stage of our decommissioning at LHSC. From chatting with our facilities guys who did decommission one of our systems, they didn't really have any challenges. So we actually had 3 separate centralized systems at LHSC. One of them's gone. It was dedicated for dental. And there weren't any issues with the alarms that they had mentioned to me. I think they just shorted them out. Like there's a way to just deactivate the actual alarms for themselves.
Stefan, do you know about any issues?
I do know that one of the photos that our engineer sent us showed something being disconnected, and then you see the alarm panel and the nitrous portion is completely blanked out. So there was a technical solution to that that wasn't very complicated. Maybe one other piece of information I could add to anybody who's thinking of building a new hospital. What we've seen in Quebec in the last year is people incorporating the nitrous, paying for all this to be installed, and then never commissioning the systems because there is no clinical use.
So we are just past our time here. If anyone has any final questions, feel free to add them. But you can also, as Anita mentioned, send me an email. I put my email in the chat. And I'd be happy to connect you with any one of our speakers. I will ask, we do have a webinar exit survey. I'll also be sending a follow-up email with this survey along with the recording, but I'm going to put it in the chat now. If anybody has 2 minutes to go through that, we would really appreciate it. I want to say thank you to all of our speakers for being here today. And Anita, I don't know if you have any final words to close us out, but.
No, thank you to all our speakers, and thank you for all of the attendees who have volunteered their time to listen. And please reach out if you have any questions. We are here to nix the nitrous across the country, and my email is also on the first slide. Thank you very much.